All right, very good. I think it would be a good time to go ahead and get started. My name is Dr. Ron Hassanzadeh, and I'm going to go ahead and get started here on the presentation in regards to the virus. So we're going to be presenting on the proper precautions and protocols of the COVID-19 in private practice and institutional dental practice. It's presented by Dr. Ricky Harrell and Dr. Abtin Shahriari, as well as prepared by Dr. Ron Hassanzadeh. So Dr. Ricky Harrell is Program Director at the Georgia School of Orthodontics, Diplomat of the American Board of Orthodontics, Commissioned Officer in the U.S. Army Reserve, 919th. He served as faculty at the University of Colorado, as well as obtained a master's at the University of Pacific. Also served as a Program Director of Orthodontics at the Medical University of South Carolina, and also was in private practice for many years. And his DMD in orthodontic residency was obtained at the University of Alabama School of Dentistry. We have Dr. Abtin Shahriari. He goes by Dr. Abtin, and he's an oral maxillofacial surgeon here in Atlanta. He's owner of the Greater Atlanta Oral Facial Surgery, also an attending at Gwinnett Medical Center and Northside Hospital. He's a renowned author on multiple scientific published papers, also worked with the CDC on polio eradication in Bihar, India. He's also a board member of the Persian Dental Society, as well as obtaining his DMD at University of Pennsylvania and oral surgery residency here in Emory University. And my name is Dr. Ron Hassanzadeh. I am a resident at the Georgia School of Orthodontics, as well as the president of the Persian Dental Society. I am a dental practice owner and practicing dentist as well. I obtained my DMD at Nova Southeast University and a Bachelor's of Science at Georgia Institute of Technology. So our course objectives are to define the COVID-19, describe its pathogenicity, present current knowledge about the virus. Also, we are going to describe the clinical signs and patient symptoms of the virus, method of transmission, and the reach of the virus. Additionally, we're going to be evaluating understanding proper precautions that should be taken in institutional practice, as well as advise what we should tell managers and employees in institutional practice, mitigate fears and concerns, and educate them in order to answer patient questions. Also, we're going to be doing the same objectives in private practice by understanding the proper precautions, as well as advising managers and employees on what to do in private practice to mitigate fears and concerns and educate them in order to answer patient questions. So I'll turn it over to Dr. Abtin. Dr. Abtin, if you would
Sure.
Take the screen.
All right. Thank you very much, everyone. This is Dr. Abtin Shahriari. I will make it very short and to the point. The point of this presentation is, what do we know about COVID-19 and what do we need to do now? The objective of this presentation is, first, I will review the epidemiology of COVID-19, clinical signs and symptoms, and how to stop the spread of this virus and what can we do now. A little bit of history on this virus. It started in Wuhan, China in December 31st as a Wuhan pneumonia of unknown cause. By end of December, there were these 27 cases were reported to WHO, and mid-January, the virus was isolated and sequenced. By mid-January, 17 million people in China were shut down or quarantined. And by the end of January, 1 billion people were shut down. Now, by January 31st, 2020, Health and Human Services declared public health emergency in the US. And by March 11, it went from epidemic to an pandemic. It was categorized as pandemic. Now, which patients are at the highest risk is our elderly population, comorbidities, and cancer patients. As of March 15 per CDC, the cases that are shown globally are 53,517. Deaths globally is 5,735. But I want to caution you guys, if you go to the next slide, those numbers are just underestimated. if you look at this chart, United States have 5 tests per million. And if you go down the chart and you see Italy and you see what's going on with them, they have 826 tests per million. And we see where Italy is at this time. So that means we have not scratched the surface in the United States of the number of cases that we have. What are some of the key symptoms? The key symptoms coming out of China is fever. 89% of patients have fever. 68% of the patients have cough, and sputum production 34%. So it's not necessarily the usual flu that we have, the symptoms we have flu. But please note, the most important thing is that 44% of the severe cases that present to the ER, they are afebrile. That's what's concerning. The incubation for this virus is about 4 to 7 days. Again, these data will change daily. That's why there's a range. There was an article that was published yesterday. Somebody said 24 days. So we are just sticking to the majority of the population and where the incubation is, 4 to 7 days. And during the transmission, the patient could be asymptomatic or pre-symptomatic for 5 to 7 days. So that means a patient walking into our office carrying the virus, we would not know because that patient would not have any symptoms for 5 to 9 days after we see them. Unfortunately, this disease is in the nasopharynx and there's a culture for it. So there's a test actually to find out. Now, the severity, again, to take it with a grain of salt, is 1 to 2% of those patients that are symptomatic will pass away. But again, this is from limited number. As we get more data, as we do more testing, not only in the United States, but globally, this number will change. It's been as high as 4% in China. And it's much higher in patients who have comorbidities such as cancer and heart disease, hypertension. So these are our older patients. And everybody says the severity is highest in our older patients, but the younger people also do get it, including children. Although they have fear or no symptoms, and the risk of death is much lower, 1 to 2%, but they can be carriers and they can be source of spread as well. The contagiousness of this virus, on an average, it affects 2 people, depending on the circumstances. And they have compared it to pandemic flu. The last time there was a pandemic such as this was 1918, which 15 million people passed away worldwide. Implies that nearly 50% of the population has to become immune to stop this spread. That means either getting it or through vaccine. So again, this is a very important point. The only way that will happen is if our population gets 50% immunity. That's how it will stop the spread. There is no specific treatment for this. They are combining multiple antiviral treatment. There's all kinds of experimental meds, supportive care, the patients who end up in the ICU. And so as of this point is experimental. What can we do to stop the spread of COVID-19? Our goal right now will be to flatten the curve. You heard this phrase from Dr. Fauci that says flattening the curve. That means we do not want to overwhelm our ER. That means if we do not stop the spread, the cases will increase dramatically, exponentially, and they all end up in the ER. And basically, we don't have the facilities to take care of the patients. The lesson that was learned from the last pandemic of 1918 was the social distancing. There was a big parade in Philadelphia, which if you look at the history, there was no social distancing. They carried on with the parade, and that was a larger spread during the 1918. So we learned something from that pandemic. So what does that mean during this time? Basically, we'll be canceling public gathering, closing businesses, shops, restaurant, as you can see and you see in the news, et cetera, et cetera, et cetera. Why is it important? As I mentioned, it's very important to flatten the curve, not exponentially increase the spread of this disease, which what will happen is overrun our ERs and our healthcare facilities. If we do that, fewer people will get infected in the epidemic phase. Epidemic phase is a smaller population that are affected, and usually finding the cases through the EIS officer from CDC is much easier. When you get pandemic, it's all hands on deck. You have to throw everything you have at this. You cannot control it. It's past the epidemic phase. Those who do get infected during this flattening curve will get it later, which is better. And also the peak demand on healthcare is less during this phase as well, because of a shortage in ICU beds and ventilators. Right now, if you just look at the news, what's happening in Europe, they have to decide who gets the ventilator, and we don't want to get to that point. COVID-19, how does it transmit it? It's transmitted through droplets, aerosol, and contact methods. Virus is in the air for 3 to 5 hours and on surfaces up to 9 days. Again, I want to repeat this. It's transmitted via droplets and aerosol and contact methods. The most procedures that we are performing is basically a source of aerosol. Conditions in Italy, Spain are example of what happens when the rate of contagion due to this virus not immediately slowed down. The Surgeon General actually a couple of days ago canceled all hospital cases that have been elective surgeries, elective consults, everything has been canceled, only emergency situation in the hospital because they will need the staff to help out in the ERs. Most private clinical practices are moving to telemedicine. Where are we with the vaccine? 35 companies are working on vaccine, different methods. They're just concentrating on different part of this virus. The RNA vaccine, which is in the pipeline but 9 months away, is not that predictable and never been mass produced. But that's the closest thing we are on. And to get to DNA vaccines are much more promising. But when you look at the data, they're talking about 2022. I'm sorry, there's a mistyped. It's 2022 when that vaccine is out. Right now, they're talking about doing the antibodies, but the preliminary research has shown it's over inflammation and causes more harm to the patient. So everybody, 35 companies are working on it, but there's nothing as of this point. What is our take-home message? COVID-19 is not a flu. There is a prolonged shedding of the virus, and there's no treatment at this time. And we have passed the epidemic and containing this virus to the mitigation stage in the US. And we are 10 to 14 days behind Italy. Flattening the curve is the critical thing that we can do at this time in order to give a chance to our healthcare system to meet the anticipated increased demand. Again, the most important thing is what can we do at this point? Because of the practices that we do, is most importantly to stay home, close offices. Even the ERs do not have the N95 masks, the protective gowns, and we know how this virus spreads through the air and stays in the air for 3 to 5 days, that patient will come and sit in your office. They're asymptomatic. They spread that into the office, your staff. They go home and they spread to their family, and everybody in our offices will go home and spread to their family. That's how it increases. It will increase the number of patients that we'll be seeing soon if we just not maintain the 6 feet apart rule, closing down all the restaurants, offices, big meetings, And it's very important to, when you read on social media, I wouldn't look at social, I do look at social media, but I'll read things with a grain of salt. You go to the trusted source like cdc.gov, NIH, WHO, those places, or ADA, GDA, those places you have to get your resources, not on social media. Now, there will be a new protocol coming out soon on how to treat our patients safely in our next presentation. And I would like to thank you for the School of Orthodontics, Dr. Harrell and Ron, to putting this meeting together. Thank you.
Very good. So I am going to continue on with what Dr. Abtin has been discussing. And as he had mentioned, the source of transmission can be direct transmission through cough, sneeze, or droplet inhalation. This is also can be spread through contact transmission through oral mucous membranes, as well as nasal and eye mucous membranes. So when we discuss the airborne spread, in the dental setting, it carries invariable risk. Droplets and aerosols produced as a result of dental procedures add to this risk, as well as using high-speed dental handpieces that can produce aerosols that linger in the air and eventually land on surrounding surfaces. And that leads to potential contact spread. So dental professionals are in frequent direct and indirect contact with human fluids, saliva, blood, as well as patient materials, contaminated dental instruments, as well as contaminated surfaces. And so in this diagram, you can see whether when a patient presents, whether they're symptomatic or asymptomatic, if they cough, sneeze, droplets can go in the air as a result, as well as contaminate specific surfaces. This can also result in aerosols produced with dental handpieces that can have direct contact with dental professionals, or again, land on surfaces that have indirect contact with dental professionals. So it's important to know these things in order to be able to know what precautions to take. So the precautions in private practice, many practitioners are available for emergency care and trying to limit the risk of exposure by limiting all elective procedures. But in the case that you do need to see an emergency in your dental office, it's important to have patient evaluations. Consider a questionnaire for patients to fill out prior to their appointment. Evaluate patient temperature upon arrival, and be aware of any patient exhibiting symptoms. Also, it's important to have staff evaluations, checking staff temperature, checking staff recent travel history, and evaluating staff for any signs or symptoms, and consider sending them home if they do exhibit any of those. With hand hygiene, it's appropriate that hand hygiene is a routine prerequisite for dental practice. However, it is a good time to reinforce this to managers, employees, staff, both clinical and non-clinical, for good hand hygiene. So washing our hands before patient exams or procedures, as well as after contact with patient or surroundings, is advised. Furthermore, mouth rinses before dental procedures has been cited in literature as a way to reduce microbes in the mouth. Chlorhexidine is unknown in its efficacy of eliminating the virus. However, oxidative agents may be effective rinse, such as 1% hydrogen peroxide and 0.2% povidone. If you do use that, keep in mind that additional saliva produced or other aerosols that are produced may also be present after that rinse that does not entirely eliminate that risk. But it has been shown to help in that regard. So from a disinfection standpoint, it's very important to follow strict disinfection protocols. Cleaning surfaces in the clinical settings, the operatory sterilization, including the area around extraoral imaging machines such as panoramics, CTs, or Ceph machines. It's also very important to clean the surfaces in public settings, such as the patient lobby, patient checkout or check-in, as well as the staff lounge. And so in regards to contaminated surfaces, as Dr. Abtin had mentioned, it's possible for the infectious surface to remain from anywhere from 2 hours up to 9 days at room temperature and persist better in a more humid environment. So keeping a clean, dry environment in dental offices would help decrease the persistence of the 2019 NCOV. And so these are the sources that I have cited. And as Dr. Abtin had mentioned, do follow the ADA and CDC for regular updates as this information is being added. And from there, I'll transition to Dr. Harrell.
All right, my name is Rick Harrell. I'm the program director at Georgia School of Orthodontics. And if you had told me 15 years ago that I would be on the forefront of managing a viral outbreak in a large institutional practice setting, I would have asked what drugs you've been taking. The challenge to us as an institutional practice, we're orthodontic providers. So we're a, quote, elective, if you will, healthcare program. And one of the issues that we need to be aware of is being able to make that line between, draw that line between panic and prudence. And sometimes that's very hard to do, especially with the sensationalization in the media.
And I take this very, very seriously, but the only thing I can remember in my dental career that garnered this much attention was the outbreak of AIDS in the early 1980s, and I was actually in the United States Public Health Service at that time. So it can be a daunting task to know what to do given the exposure in all forms of the media. We've had mixed messaging from the top about this. And also what's just confounding about this is the rapidity with which this situation has evolved and continues to do so. To give you a little background about this presentation, I started this last Friday afternoon when we decided this is going to be a go. And my presentation is completely changed as of yesterday around lunch than it was previously as far as what we were going to do as an institution at the school. So our institutional practice measures to prevent the spread of this disease is very similar to that of private practices, but we have this overlay of a greater size patient population. We have 5,200 active patients here at the school. We have an increased number of staff and patients that we have to deal with. And we also have quite a few residents that are very concerned about this and their own health. To put this in perspective of other pandemics, and this doesn't mean that we're not going to get there, but this goes back about 200 years. And if you look at the big green ball here, that was the Spanish flu. It killed 40 to 50 million people. I did some math today about it. I can only do simple math, but I took the death numbers here in the US. So we're looking at a 0.0002% chance of somebody dying from this compared to our population. And so if we look back at the Spanish flu, we had 40 to 50 million people, which is significantly greater. If we look at where we are on the spectrum, this little red ball is down here at the very bottom of the sheet, is where we are with the COVID-19 virus. So if we take some prudent measures right now, and as Dr. Fauci said, we need to hunker down some, I think that it's not going to be quite as bleak as we might imagine it to be. But remember, I'm forever the optimist on a lot of things. But this does give you some perspective of some of these others. This was a cholera outbreak in the 2 centuries ago. Here's our ongoing HIV/AIDS epidemic that started in the early 1980s when it was brought to the U.S. So here we are right now with the coronavirus. This is not to diminish it at all. I just want to give people some perspective about what we're facing. And if we get all over this aggressively early, I think we can hopefully bring this under control fairly quickly. What are the layers of defense to prevent the spread of the disease? And
These items that I'm going to go through are kind of ubiquitous among the university and hospital-based ortho programs in the United States, as well as the dental schools. Over the weekend, I looked at 40 websites, and that quickly grew to over 70 websites. And I communicated either via email or phone call with a number of program directors in the United States. And the responses were all pretty similar, with the difference being in clinic closures, which as of last Friday, were 3 where the schools have decided to shut down. And today, we're at a much greater number. Last count that I could determine from going through the websites was about 23 programs had closed their door to everything but emergency visits. And a lot of that emergency visit contact is being done by faculty within the institutions, and they're keeping their students and residents out of the loop. So the first line of defense that institutions put out was patient screening via questioning. So I looked at a bunch of questionnaires that schools were putting out, and here's our common ones. Obviously, are you experiencing any symptoms? The dry cough, fatigue, shortness of breath, muscle pain, sore throat, flu-like symptoms, fever, vomiting, or diarrhea. And maybe the diarrhea one would help push us over the edge on the run on toilet paper. But if you answered yes, the appointment was deferred for 21 days, and you can see a patient if the answer to this was no, as well as the next 2 questions. The next question, have you traveled outside the United States in the last couple of days or weeks, or have you been on a cruise ship in the last 21 days? If yes, even without symptoms, the appointments would be deferred for 21 days. If no, then you could appoint.
Do you live with or have had contact with a person with COVID-19 diagnosed or exhibiting symptoms listed above? If yes, defer for 21 days. If no, then appoint. So you would have to answer no to all those questions. Now, some of the institutions I found had more specific questions about where the travel occurred, and they specifically targeted China, South Korea, Japan, Iran, Spain, France, or Germany. And some programs were also inquiring about travel to California or Washington State within the past 14 days. So these types of questions were generally asked when scheduling an initial or a follow-up appointment, either by phone contact by the scheduler or the text message or an email appointment reminder. So effective March 23rd, GSO patients will be asked these 3 specific questions, weather permitting, outside of the reception area. So we'd already decided to try and keep people who are possibly ill from actually entering our building. These questions are posted on the entrance to the reception area, at the front desk, at the door to the clinic entrance area, by the entryways to the treatment bays, and they're again asked of the patients by the treating area, and they're well triaged prior to sitting in a chair. So the other day I was in the clinic and noticed the residents were reiterating those questions to the patients. Okay, information on our website, which has just been recently updated, are shown as follows here. I'm not going to read all of this to you, but we wanted to relay to the patients that we were very, very concerned about their health as well as the health of our staff and our residents. What about taking the patient's temperature? This past week, the Secretary of Health and Human Services, Alex Azar, reported that asymptomatic spread, or symptomatic spread, is not the major driver of the spread of the coronavirus. The CDC echoes that belief. The coronavirus response coordinator, Dr. Deborah Birx,
she struck a different note on asymptomatic transmission. She raised the question about people who are under 20 possibly being ones who are spreading the virus to others. So in an orthodontic practice, that's the bulk of our patient population, are people, young people who are under 20 who appear to be healthy. So it was also noted that
you can be a carrier of the virus and infect others and not have symptoms such as temperature, running a fever. So we currently were not taking temperatures as a part of the screening process. This was the protocol from the University of Alabama, Birmingham that I was able to get. This is before the appointment, and you can see these questions up here. And so it just makes for a nice decision tree. And if you get a bunch of no's, you can get over here to an appointment. But if you have some yeses in there, your appointment is deferred and possibly referred to your physician. That has changed for UAB because they are closed now to all elective clinical procedures, and any emergency visits are being done by the faculty. Here was their screening table for at the appointment, and they had actually set up an isolation room within the dental school where they could take these patients who they suspected may be infected and have them seen by a physician. So they went a little step beyond what most places might do, and certainly what you'd be able to do in a private practice setting. Here's the Medical University of South Carolina screening protocol, and notice it goes through the same thing. One, there's a question about travel outside of the United States, and have you been in close contact? Have you had some symptoms in the last 14 days? And there's a list of a number of actions that they're instructed to take, such as masking the patient themselves once they're in the facility. So we don't have a unified response to it, but we're pretty much following the same basic principles as we try to combat this disease before it gets into our programs. Patient screening, all the staff and providers at MUSC were responsible to ask the questions in the screening form, and they were also aware that some of the patients weren't seen until they got up to the check-in kiosk, and some have been instructed, they were instructed to contact the front desk if they answered yes to one of their two big questions. So this is why we are asking providers not to assume that the front desk staff already screened the patients, but to be proactive and ask each patient the screening questions. So they were also sending these questions to the patients prior to their arrival through the Easy Market system via text message or phone call. Temple University, they had a 4-stage check system to try and isolate patients, faculty, staff, and students and residents from entering the school if they had traveled to high COVID-19 areas or experienced any of the following symptoms. And you can see that the questions are basically these universal ones that we've been talking about, but I wanted to show you something else that came out of the Temple document. We're talking about supplies. As with all dental practices and healthcare providers, we use universal precautions. And typically that shouldn't present a hardship on either the institutional practice or a private practice, except for the one caveat, the ability to access adequate supplies. Just as has happened with private practices, masks especially, gloves not so much, are in short supply. So I went through our clinic the other day, over the weekend, and I just pulled out some of our personal protective equipment. Here's our face mask, and we can see made in China. Here's our cotton gauze packets, made in China. Here's our hand sanitizer, made in Germany. These are all on the list of at-risk companies. And so the supply chain may be interrupted for who knows how long, and may prevent you from being able to access the supplies. The N95 respirator mask, good luck finding those right now. This came from the Temple document. They said that personal protective equipment during aerosol generating procedures in the oral surgery and sedation clinics consisted of full personal protective equipment, gown, gloves, level 3 mask with face shield and goggles. Notice the next 4. N95 mask when available, on order. Bonnets, on order. Full gowns, on order. Shoe covers, on order. So almost all of their supplemental supplies were unavailable to them. I have a daughter who works in a hospital emergency room for a large hospital chain, and they've been instructed to reuse their mask, and they've even gone so far as to put the mask under lock and key so that patients or personnel can't steal them from the emergency room. So this supply shortage is real in our profession. Third line of defense, limitation of procedures. Ron briefly talked about aerosol generating dental procedures. If you have to do them only with a dental assistant using high volume evacuation and rubber dam. The use of Cavitron and ultrasonic scalers is prohibited in dental practices now. They're even asking people not to do rubber cup prophies. I think we'll see a statement by the Georgia Dental Association. If it hasn't come out already, I think we'll see one very soon. But these items were taken from the Temple University protocol. So the CDC has weighed in on this, and so you should not treat anybody that has any of these flu-like symptoms, and you must avoid aerosol-producing procedures. Reschedule them for 14 days or more out in the future. At GSO, we were going to suspend these procedures when our students came back next week. Debondings because we produce aerosols when we remove composite. Bondings because when we spray the acid etch and rinse it off teeth, that produces an aerosol. Significant rebondings, if you have that problem child that breaks a few brackets every time, they were just going to go without their brackets for a while. Interproximal reduction procedures or trimming of incisal edges where there might be some aerosol produced. We were going to discontinue those, as well as laser surgeries because it does produce a vapor of tissue that's being lasered, and it doesn't always get sucked up into the high volume evacuation system. So these all presented a danger. What was going to be the fourth line of defense? Social distancing. And we were going to, and we are suspending all classes and classroom activities. And we are set up well to do learning distance, or distance learning procedures. And as soon as this became apparent that schools were going to have to shut down, the Commission on Dental Accreditation sent us all a love letter stating that they wanted us to report how we were going to do the distance learning, how is it going to be reported and verified, and how are the students going to be assessed on this. We were going to ask that non-elderly persons accompany minor age patients. We often see grandparents bring grandchildren to their ortho visits here. So that was another line of defense. We were going to limit access to the clinic area. We were going to encourage parents to wait for their minor patients in the cars as opposed to sitting in our waiting area. We could text them for consultation, or the resident can accompany the minor to the car to actually speak to the parents to cut down on congestion in the reception area. Fifth line of defense, increased hygiene outside of the clinic. Our classrooms have all undergone a thorough disinfection after the students left for spring break. We're having calls twice daily with our administrative group over the spring break. So we're trying to do everything we can to manage this appropriately. Sixth line of defense, which we went to yesterday. Closed clinic operations. When I typed this up, only Jacksonville University, University of Maryland, and University of North Carolina had suspended orthodontic clinic operations. we're going to go into some updates in just a second, but I wanted to include this in the presentation to show the audience how this was evolving even at the institutional level, because we've never quite dealt with something quite like this. So we've closed all our non-clinic operations and clinic operations until March the 30th. We may add additional closure time according to the CDC, and I suspect that we will. According to Georgia and local health department advisories. The decision was made yesterday morning with principals involved. And then as of this morning, 20 programs have suspended all non-emergency care. Some schools have faculty only seeing emergency patients. And I want to address the response of institutions across the country. It's all over the board. We have some programs that when you go to their website, there's absolutely nothing said about the COVID-19. Even if you Google it, or if you type in COVID-19 response in the search box on their website, it directs you to a Google search engine. So it ranges from no response that's publicized to some where you click on and the first thing is you see the ubiquitous picture of the COVID-19 virus with a detailed explanation. For some of the programs, it's very difficult to ascertain whether or not the clinics are closed. Like I said, some have the COVID-19 advisories prominently on their websites. Some direct you to Google search. And some programs are advertising enhanced questioning and screening as their method of keeping this out of their buildings. So what I did was I pulled down, just downloaded a map of the United States, and all these stars are the locations of where dental schools and orthodontic programs have shut down their regular course of business. And so we're right here in the middle of Georgia, and you can see we're pretty well surrounded by programs. I could not find out anything from Mississippi, LSU. The Texas programs were a bit elusive on this. Oklahoma, as of this morning, had not shut down their programs, nor had St. Louis University or University of Missouri, Kansas City. And I could not find information about Tennessee and clinic closures specific to dental clinics. So I took these statistics this morning at 7 o'clock. Fulton County, Georgia had 20 confirmed diagnosed cases of COVID-19. In Georgia, there were 121 cases. 2 days ago, there were 99 reported cases. The one death is of a 67-year-old male in a hospital in Marietta, Georgia. 44% of the cases are age 60 or over, which I found surprising because I thought a greater percentage would be in a more elderly population. In the United States, as of 11:26 p.m. last night, there were 4,450 cases, 85 deaths. And these statistics may vary just a little bit from Dr. Abtin because the information is all over the place. There is not one source that gives you everything you want to know. But 182,000 known cases with 7,100 deaths. Down here is listed a website called ourworldindata.org/coronavirus. And if you go to that website, it will show you all the countries where coronavirus is present. And it has these nifty little graphs that show you the exponential rise of the disease in those countries. So I thought it was a wonderful resource, and it's the first time I stumbled on it this morning somehow in one of my Google searches. So it gives you very graphic information about what's going on. So to sum this all up, first of all, thank you all in the audience for tuning into this. It shows you're interested in taking care of your patients and that you're seeking out information. We are all in uncharted territory. Good clinical practices and universal precautions coupled with an increase in screening procedures and the limitation of clinical procedures are in order to prevent the spread of the virus. And I think we can say now that it's probably prudent just to close operations except for significant emergency care that's needed. You need to look at the CDC website and state and local health department recommendations to follow this. And one of the things I noticed was, even though the protocols are a little bit different, there are a lot of commonalities among the various institutions that are using these. So, all right, if there are no other questions, we'll wrap it up. Thanks, guys.
Thanks, guys. Thank you.